και είναι και αναπληρωτής καθηγητής στο George's, στο Πανεπιστήμιο. Τέο, θα μας το πει στα αγγλικά, έτσι, καλύτερα.
Θα σας πω καλησπέρα. Καταρχήν είμαι πάρα πολύ εντυπωσιασμένος στο ότι υπάρχουν ακόμα 36 άτομα εδώ. Πρέπει να σας πω ότι στην Κύπρο μέχρι τώρα θα πίναμε τη δεύτερη μπουκάλα ζιβανία. Θα σας μιλήσω στα αγγλικά, διότι στα ελληνικά πρέπει να σκεφτώ στα αγγλικά και μετά να μεταφράσω και θα χρησιμοποιήσω το διπλάσιο χρόνο και είναι ήδη αργά. So, we're going to discuss the management of PVR. I'd like to thank the organizers for their kind invitation. We always have a great time at this meeting, so thank you for continuing to invite us. So what is PVR? PVR is the description of the proliferation of membranes in the epi and subretinal space, causing retinal traction and shortening. It continues to be the commonest reason for retinal detachment failure. 5 to 10% of cases of retinal detachment will get PVR, and that increases to about 40% if there is a giant retinal tear, and 45% if there is penetrating trauma. 75% of failed retinal detachments are due to PVR. So it's a major problem in retinal detachment surgery. Now, it was first classified in 1983, and that classification was deemed too simple because it wasn't descriptive enough. It was reclassified in 1989, and that classification was too complex because it gave you too much information, and it finally, we ended up with classification which was modified by Mackamer in the early 90s. And it's very important to have a classification if we're going to do research work and communicate between us what we're talking about. So the pathophysiology of PVR starts with the breakdown of the blood-retinal barrier, and which induces cellular proliferation. The main cell of PVR formation is the retinal pigment epithelial cell. But fibrous astrocytes, fibroblasts, myofibroblasts, and inflammatory cells play a role in this complex process. So what happens is that RPE cells change their phenotype, they lose their contact inhibition, they start to multiply, and they become like fibroblast cells that cause retinal shortening and contracture. The amount of cellular proliferation correlates very well with the breakdown of blood-retinal barrier. So if you measure the amount of flare in the anterior chamber, it matches very well with how many cells are proliferating in the posterior chamber. The main cause of poor vision, of course, is that the retina is detached for a prolonged period of time, and photoreceptor apoptosis is what contributes to that. So the change of the retinal anatomy kills off the photoreceptors. So PVR in general has a poor visual outcome. Now, there are many growth factors that have been identified to play a role in this cascade of events. Platelet-derived growth factor and tumor growth factor are the main two, and many of these have been tried to modify by various pharmacological agents. The main risk factor for PVR formation is multiple and large tears. If there is a vitreous hemorrhage, there are already cellular components in the vitreous, and that adds to the cellular load. If PVR already exists, then the chances that PVR will get worse is more. If there is choroidal detachment, or if there is pre-existing uveitis, then the blood-retinal barrier breakdown is already there. And aphakia and perforating trauma are major contributors. Now, the main problem with PVR is that what we do to treat PVR causes PVR. So doing a vitrectomy increases the chances of PVR, but that's what we do if we have PVR. Through doing cryo or doing endolaser increases the risk of PVR. These are factors that have been associated with the formation of PVR. And of course, multiple surgical procedures increase PVR, and so does injecting gas. So our treatment to treat PVR causes PVR. So it's a vicious cycle. So what's our treatment? Our treatment, of course, remains primarily surgical, but there are pharmacological manipulations of our surgery. There are various agents that have been tried. The one that has really stood the test of time is triamcinolone. Triamcinolone, although most vitreoretinal surgeons will use in severe inflammatory PVR. There are very few studies that show definitively that statistically you get an improvement, but there is lots of work out there that has shown that there is some benefit to injecting triamcinolone in cases of PVR. There was some very good work on 5-FU and low molecular heparin, and initial results were very encouraging that if you infused 5-FU and heparin in cases of retinal detachment, you will reduce the incidence of PVR. That didn't stand the test of time. Later studies showed that this was not statistically significant. And the other thing is that retinal detachments where the macula was still attached that were infused with 5-FU ended up with lower end final visual acuity. So 5-FU has more or less left the playing field. There are other anti-growth factors that are being tested, but to date there is no fixed or standardized pharmacological way to control PVR incidence. So what's really changed in PVR? I guess it's small gauge vitrectomy, good viewing systems, we can see better, we don't traumatize the eye so much, so we're becoming better at treating PVR. Conventional surgery, sclerobuckling procedures still have a role to play, and having PVR doesn't necessarily mean you have to do a vitrectomy. What's very important in PVR is to reduce traction and to reduce the chance of PVR formation. And it is paramount that the vitreous is detached from the retina. Many cases of PVR occur because there is an incomplete vitreous detachment in retinal detachment occurrence. And peeling the vitreous off a detached retina is easier said than done. The second thing you have to tell your patient is that PVR often recurs. So you may do a wonderful procedure and do a retinotomy and flatten the retina. Membranes will reoccur. So you have to be prepared to operate and reoperate and treat the patient multiple times, and the patient has to be aware of that. It is very tempting when you get a retinal detachment to stick heavy liquid in the eye and then stick silicone oil on top of the heavy liquid. And heavy liquid and silicone oil gives you a false sense of security. It looks good on the operating table because you force the retina back into place and you stretch the retina at its maximum and it looks detached. And of course, later on, when there is a little bit of retinal shortening, the silicone oil simply gets underneath the retina. So it's very important that an adequate retinotomy and all tractional forces are released before you put any kind of tamponating agent. Otherwise, silicone oil detachments occur and they have a very poor prognosis. Once you get heavy liquid or silicone oil under the retina, and particularly under the fovea, the chances of giving the patient good vision again are very poor because they're extremely toxic to the photoreceptors, of course. I tend to avoid heavy liquid as much as I can. I seldom use it unless I really have to. And I use air to stretch the retina back into place. The advantage of using air to tamponade the retina during surgery, during a retinotomy, is that you know you've released the traction, because if you haven't, the air will get under the retina. And if the air gets under the retina, you simply put fluid in the eye and the air comes back out again. If you get heavy liquid or oil under the retina, that's not so simple. And if you flatten the retina and put it on stretch, you do bipolar before to do hemostasis, and as you cut through the retina, you can see the release of tension. And you can see here in this short video that once the retina is cut, then the retina shoots back 2 or 3 millimeters, and you can sort of almost feel the release of tension. It's like cutting through an elastic band. And once the retina sits back down in its place, it goes all the way back to where it wants to, and then you apply laser. So using air and doing retinotomy under air is a good tool to avoid heavy liquid. Of course, there are times when you have to use heavy liquid. So in a case like this, where there is severe anterior PVR and anterior PVR just behind the vitreous base is the worst type of PVR because it causes a tight ring of constriction that is very difficult to release. And the only way to release and treat cases like this is to slowly open up the funnel, use heavy liquid, and then do a big 360 retinotomy or whatever retinotomy is necessary to relieve all of the anterior traction. So heavy liquid is a useful tool. And finally, I just want to share a case with you that highlights everything we've said so far. It's a case of Sturge-Weber syndrome. It's a young man who's been followed up at Pantheon Eye Center in our glaucoma department for about 10 years. His right eye had been blind since childhood, and his left eye had advanced glaucoma, and he was sent for glaucoma management. He has epilepsy and is educationally subnormal, so it's a child with a lot of needs. He was treated with cyclodiode laser and medical treatment, and he had good control. And then his parents brought him one day and said that he had he'd lost his navigation vision. Okay? So he had this large inferior serous retinal detachment from his hemangioma. There were no breaks to be found. We gave him some propranolol, and he didn't respond. And as time went by, things got worse, and you can see on the ultrasound scan how thick his hemangioma is. We sent him off to have plaque radiotherapy, and he had very poor response to this. And as time went by, his retinal detachment progressed to an open funnel detachment, and due to following his plaque radiotherapy, he developed a total cataract. So this was a totally blind, educationally subnormal 20-year-old that was becoming extremely difficult to deal with. We tried very hard to sell him off to somebody else to operate on. He went to Israel, he went to London, and he came back. So we felt we had to do something. So on his cataract operation was slightly complex by the fact that he had a fibrosed capsule, but eventually the removal of the cataract was fairly simple because it was more or less just white, soft cataract. But what was difficult is that once the cataract had been removed, you could see that the retina was attached to his posterior capsule. So it was felt necessary to remove the capsule in order to gain access. And I was hoping that once the capsule came off the retina would fall back enough to actually gain access to the vitreous space in front of the retina. I was under the impression that what was holding the retina so far forward was its attachment to the capsule. But of course I was wrong, because once the capsule had peeled off the retina stayed exactly where it was, just behind the pupil plane. So I thought there must be a lot of vitreous in the anterior chamber holding the retina so far up. So I put some Kenalog in the eye, and it showed that actually wasn't the case either. So in fact, what was going on is that the detachment was so bullous that the retina was just inflated like a balloon, and it filled the whole of the posterior case. So it looked like an inoperable retinal detachment, really, an inoperable case of PVR. I have to admit that I almost gave up. And then I thought, I will try and drain some fluid, and drain some fluid externally using the indirect by putting a needle on a flute and going under the retina. And to my surprise, once there was fluid drained, the retina just fell back, gave enough space to enter the space in front of the retina, and there was no PVR. It was a straightforward, simple retinal detachment repair without any PVR. The vitreous peeled off the retina quite simply, quite easily. And apart from the scarring from his radiotherapy, it was a retina that it was like a standard retinal detachment. And the point I'm trying to make here is that if there are no retinal holes and there are no RPE cells in the vitreous cavity, it is highly unlikely that you get PVR. You need a cellular component to get PVR, so it doesn't matter how bad a detachment looks, serious detachments never develop PVRs. So are we getting any better at treating PVR? Well, we are anatomically, because we have better equipment to deal with it, and we're getting 80 to 90% of our patients flat. Are we getting any better at getting vision? No, we're not. In all the years that PVR has been documented, only 20% of patients with a single PVR surgery will get better than 10 to 100. And only 10% of patients with repeated PVR surgery will get that vision. Are we getting any better at preventing it? No, not really, we're not. PVR still occurs in 5 to 10% of cases. So PVR continues to be the most frequent obstacle to successful retinal detachment surgery, and it is something you need to be aware of. Number one, so that you can pharmacologically try and influence its occurrence, and perhaps more importantly, to warn your patient that they may get PVR. PVR is our suicide bomber, okay? And until, just like Trump's war on terror, until we solve the underlying problem, we'll never get rid of suicide, terrorists, or PVR. Thank you very much.
Mr. Potamitis, thank you so much. Two quick debate questions. You have inferior PVR. What do you do? A relaxing retinectomy, heavy silicone oil, or buckle? And second question, do you think for the prevention, is there any role for Ozurdex or not?
Yeah. In the first question, do I do a relaxing incision and heavy silicone oil or sclerobuckle? The answer is yes, I do both. It depends very much on the shortening. I am old enough to still believe in buckles. I know this is a big debate, and I know that a lot of people think that we shouldn't be doing, but I think there is a room for buckling people, and there's still room for encircling people. And I think that going into depending on the case, you have to decide on the spot. Just by indenting, you can get a feel whether a buckle will do the job for you. Ozurdex, I think, yes, there is a role for it. There's been a couple of publications of Ozurdex as a long-term steroid treatment for PVR. I have to say, I have no experience. We don't have Ozurdex in Cyprus, so I stick to triamcinolone.
Okay, thank you so much.
Thank you.